Hi, I'm Doug Dormer, and this is the Business of Health Informatics B641. This is Module 2, Lesson 1. Now, if this is new to you, perhaps you didn't see the Module 1 where I explain what this class is and how these videos came to be, so feel free to step back and do that. But for this module, I want to talk about a common sense approach determining and understanding the financial value of health information technology and health informatics. In this first lesson, we'll begin by looking at what's in the news and then an overview of the things that we'll be talking about in the rest of this class. Now, to set forth that agenda, after we cover in the news, the first lesson that I'll have for my students, not part of the public video, will be a focus on the evolution of the business of health IT and health informatics. After that, I'll teach you a bit about accounting as a means of measuring HI and HIT performance. Once you have a sense of how you measure the performance of health information technology, either as innovation or as investment, then we consider how do you assign a value to it? What's it worth when we compare it to other investments and priorities that an organization has to make? And then finally, we'll end up with an assignment based on this work for this Module 2. Now, last week I talked about the problems with respect to telehealth, namely that the ability to invoice Medicare comes under some particular waivers, I'll explain what that means in a moment, that were put in place during the COVID pandemic. And those waivers that allow physicians to bill for telehealth encounters expire mostly at the end of September, in a certain way, some of them at the end of December, but they're all set to expire. And it amazes me that this hasn't been in the news. So the first thing I want to observe is that sometimes it's not what's you see in the news that is the reason something should be in the news. And so then I ask the question, what on earth does that really mean? Well, in this case, we'll drill into that when we look at telehealth services. So as I say, over the last few days as I've prepared for this lecture, I haven't found anything in the mainstream news. But this morning, as I was preparing to record this, I checked one more time, and here's what I found. An article titled, "The Telehealth Policy Cliff, Preparing for October 1, 2025. Now, I got to admit, I love this image. My first question is, can I use this? Can I steal it for other places? And the answer is yes. Apparently, it's an open source image, and so if you do use it, then you have to give the appropriate reference and citation for where it comes from, giving credit where it's due. I'm glad to do that. In this case, I got it from the Telehealth Resource Center, published on just the other day on September 5th. Actually published on September 4th. I found it on the 5th. And what they say is this: without congressional action, key telehealth flexibilities that were first put in place during the COVID-19 pandemic will expire on September 30th. These extensions were tied to the federal continuation resolution. I'm going to come back to that in just a moment. With ongoing political uncertainty and many competing priorities in Congress, there's a real risk that lawmakers may not act in time, creating a telehealth policy cliff that would roll back policy gains. Well, what that means is that in 2021, they decided we better allow telehealth. Private insurers are doing it. We better allow it in order to protect the population from spreading COVID. But the way they did it wasn't to change the rules and say, all right, you can bill for this. Rather, it was to grant a temporary waiver to certain requirements that were very restrictive and have been in place. Because before that, from a Medicare perspective, you couldn't bill for telehealth services, for video encounters with your clinical staff. You could under certain constraints with respect to if you were in a rural setting, a lot of different rules. You had to go to your local doctor's office perhaps, and with your local doctor in the room, communicate with a remote specialist. That might be billable, but But other things, the way we view telehealth today, no, that was not allowed. But they didn't make a permanent change. They just made a temporary change that actually was set to expire at the end of March. But when they extended the budget through a congressional extension, a continuing resolution that ran until the end of September, they included that these waivers should continue. But they have not taken action to extend them past the end of September. So let's look at what the consequences of that are first. It means that providers will not be reimbursed for telehealth visits delivered to Medicare beneficiaries in their homes. Pre-pandemic rural and facility restrictions would return. It means that critical programs like Hospital at Home could face major disruption. It means that federally qualified health centers, FQHCs, and rural health clinics would no longer be able to serve as distance site providers for most telehealth services. And here, after December 2025, and I'll link this with the last one, while the DEA, the Drug Enforcement Agency, extended flexibilities for prescribing controlled substances via telehealth until December, providers may struggle to sustain telehealth-based care if reimbursements disappear. For our purpose, it's sufficient to say that some of the dates, most of the dates expire at the end of September. Some have an effect at the end of December. The key point is, unless Congress acts, physicians will not be compensated for telehealth services after either the end of September or December. So what might happen? You're a boss in a department. You've got a new wonderful health IT professional with his or her freshly minted master's degree. And so they'll have some questions that you and the accounting folks, it's not purely on the health IT professional side, it also extends into the accounting side, but they overlap. If it's a Venn diagram, those circles do overlap quite a bit. How much money do we make from telehealth services? And related questions. How often do we do them? How long do they ask? Things of that sort. What do we do if the law isn't extended? I can imagine someone saying, how would we change the technology to roll back what we did when we put this in place in 2021? How would we implement simply putting it on hold? How would we inform our patients and clinicians that a benefit that they have become used to and think of as a fundamental part of our system no longer will be available, and they have to come into our office as they had prior to 2021? How much will it cost to put this telehealth on hold? What should we do? Now, one of the main objectives in this course is our project, where we will identify a problem, we will quantify the harm of that problem, we will design a solution to that problem, we will evaluate that solution, predict what the impact should be from a business perspective, and determine how will we know whether it's a success. All of those things will be the main project worth half of my students' grade for this class. Here's an example, right in front of us. If we were to do the papers today, I can't imagine a more fun, in its own way, example of to try to address this, describing the problem, describing a solution, evaluating that solution. Now, I know that we have to extend our nation's budget by the end of the month. That's a whole separate issue. And I have to believe that this is just going to be slipped into that on a hopefully a permanent basis, not just kicking the can forward for another year. But we don't know. So we'll have to watch it and see, and who knows, this may be, or this may lead to subsequent questions that one of you or more of you can use for your class project. Now also, in our Module 1, I pointed you to a wonderful article called The Corporatization of U.S. Healthcare in the New England Journal of Medicine. This is the first in a series of articles. This was on July 2nd, so we've already got August and September, and I'm going to tell you about those in a moment. But on this one, I think it's significant. What we do is we create a Slack channel for our class, and then we establish discussion topics within that. And I established one topic for this article, and I asked the class to engage in a discussion. What thoughts do they have as a result of this discussion of corporatization? Now, as is often the case, my students, because this is an asynchronous class, and they're not really used to engaging in creating class dialogue, correspondence with their peers through Slack, I really only had one student who weighed in with a significant comment. And here it is. Aaron said, "But as I read that passage, my mind went to the way patients are opting out of traditional health science advice in general. As Perlis, 2024, I love it, a good citation right off the bat, note in their work, patients had a substantial reduction in trust in physicians and hospitals during the COVID-19 pandemic. It's my belief that this is in part due to the corporatization of healthcare. It's easy to understand how patients ask questions like, healthcare is getting more expensive with worse results. Why should I trust you? This mistrust in the system has led people to explore other sources of information outside traditional medicine because the costs, process, and environment to get answers today in America have become too unwieldy for patients to accept." Give yourself a gold star, Aaron. Nicely done. And to the rest of my students, weigh in, comment on this, start additional threads from the news, the things that I point out that are in the news, or from our discussions or from readings. This is the place that we get to collaborate as team members in this class. Well done, Aaron. And of course, the key question we have to always ask is, what does this mean, this corporatization, from an HIT perspective? There are a lot of ways you could go with it, particularly if you consider what's going on in the United States with what's going on in other countries, as one illustration of a direction you might take. The second article in this series, published on August 2nd, a month after the first one, is titled "The Broken Promises of Profit-Driven Medicine." Now here they give an excellent history of medicine between the 1920s and the 1960s, how initially physicians became the locus of power, then how hospitals really became, and health systems became the center of power, how the profitability of healthcare led to venture capitalists and investors generally to today's corporatization. It's an excellent piece of the summary that I intended to cover in the second lesson of today. So I'm going to encourage all my students, and everyone frankly, to read this article. And then the third article that came up is from August 30th, but really hit the press on September 4th. It's called "The Corporatization Deal, Healthcare, Investors, and the Profit Priority." Two quotes from this particular one. "Corporatization represents a deal between organizations and investors. New technologies, upgraded facilities, research and development, and competitive salaries are expensive, but are necessary to meet the expectations of patients who value improvements in health more than improvements in other goods. Investors supply the capital needed to support these enhancements and, in exchange, expect a financial return on their investment." It goes on. "Although the terms of such investments vary, the goal is clear. The organization receiving the investment must make a profit. If it doesn't, the investment can be deployed elsewhere. Corporatization unlocks capital in return for growth that prioritizes profits, and investors may take an ownership stake in an organization or adjust management incentives to generate the necessary profits." Well now, feel free to comment on that on our Slack channel as well. Now, going in a different direction of what's in the news, this was in the New York Times this week. In Austria, physicians can prescribe essentially that you need to go to a spa for 3 weeks or 4 weeks or 5 weeks. And as you'll read from the article, it talks about this not being just a lazy camp, but rather you're pretty much assigned to things from, say, 8 o'clock in the morning till 4:30 in the afternoon, although some of what you might be doing is meditating or sitting, being still. So it's intended to address stress, diet, and the management of chronic disease. But the thing is that this national health system has determined that these lifestyle programs save total health cost. So here's a second example of something we might do in our class. You might, and you can make up things as you go, say a major private insurer fund that is working with employers has determined that the model in Austria and in other countries should be implemented in the United States. And so you, as the HIT expert, have been given the task of assessing that opportunity. So what's the situation that has changed? What is the problem we have that is related to technology that needs to be addressed in order for us to implement perhaps this kind of care in the United States? What would a solution look like? How would we evaluate it? What would we expect from it? So here is a second example of an opportunity, of a problem statement, problem area. This isn't the problem statement, the problem area that you might well use in our class. And I think in general, it's a fascinating topic for all of us to consider. Then next in the news, as you may be aware, there is an awful lot this week going on about the Secretary of the Department of Health and Human Services, Robert F. Kennedy Jr., and his challenges to vaccines and other health standards. And so here's a link to an article. That's actually the press release from California, that California, Oregon, and Washington are launching a West Coast Health Alliance to uphold scientific integrity in public health. Essentially, they're filling a role that previously was filled by the CDC. And there's some short information here about it from that press release. It's in response to recent federal actions that have undermined the independence of the CDC. And in coming weeks, the Alliance will finalize shared principles to strengthen public confidence in vaccines, while each state will independently pursue strategies shaped by their unique laws, geographies, histories, and peoples. These shared principles will form the foundations of the alliance. And then this next line, importantly, the three states affirm and respect tribal sovereignty, recognizing that tribes maintain their sovereign authority over vaccine services. Here's another development that warrants significant work by health IT professionals and might make an excellent project for this class. In fact, a little bit later, not just yet, I'm going to try to reach out to some of the public health officials or major hospital people or health information exchanges in these three states and see if we can't engage them directly in a discussion about the role of HIT to help them solve this problem. Another tremendous example of an opportunity where the work you're doing in your master's program has real world value and where the problems and not projects, problems lead to projects that will be of tremendous opportunity. Again, what does it mean from a health, IT, and HI perspective? Now, given that I've focused on some of the problems and such, I felt it worth putting in another piece. This is an opinion piece in the New York Times. American healthcare gets a lot wrong. Here's what it gets right. And I'd encourage you to read this. It's really a very good article about the things we've done right in the United States, the strengths that we have. And the upshot is, it says, let's be careful not to completely destroy the system, but rather to improve the system. And it gives some ideas on how to do that. Again, good material, but in a positive tone about what we can do. And I would encourage you to read this as you're thinking about what kind of a problem would I like to address in this class. All right, that's in the news. There's more stuff, actually, but that's plenty. I'll add a few more things, including some articles published by our own faculty and students from Indiana University. Now let's look at the agenda for this module. We've done the in the news. Next, I want to talk about the evolution of business and health of HI and HIT. Then we'll go to accounting to measure the performance. And then we'll talk about translating performance to value, and we'll have an assignment. But I'd like to tell you a bit more about what that means. When we get to accounting, what we're going to do is talk about accounting performance at the organization or department level. We'll look at a balance sheet. What does it mean, a balance sheet? What's its purpose? And then we'll focus on the income statement and the net income as a measure of performance of some organizational entity. Then we'll translate that to say, all right, if that works at a department or an organization, how do you think about the profitability, for example, or in this case, the net contribution of a particular health technology strategy or investment? Once we have a sense on how you can evaluate those from an accounting perspective, from a financial perspective, then we're going to address the question of valuation. We'll talk about the means by which you can do that. You might use, for example, calculating the present value of future cash flows, and from that, calculate an ROI on investment. Then we're going to look at multipliers. Perhaps a better way to value it would be, what's the market tell us? What are investors and purchasers willing to pay as a multiple of revenue associated with either an organization or even with respect to an investment, a technology? And then we might also look at cash flow, which is expressed as earnings before income tax, depreciation, and amortization. And with all of that, we'll be ready for assignment 2. But hold up. Don't go away yet. I'm going to keep this and extend into my lesson 2 for my public video as well, because I think it's so interesting, and you'll see why. Now, earlier I said look at the New England Journal of Medicine article for the history, particularly beginning in 1920, around 1920. The Broken Promises of Profit-Driven Medicine gives an excellent discussion of the shifting power elites in healthcare, where physicians initially had the power, moving towards hospitals and hospital systems, healthcare systems, moving to investors and financial folks, leading to corporatization. Now, I think that's a wonderful history beginning in 1920, but I think it misses a big part of the history. This may be enough for health information technology, but you can't really grasp the history of healthcare that sets the stage for health information technology unless you look at this book, The Great Influenza by John M. Barry. Now, first of all, it's a global discussion, so it incorporates the rest of the world, and it really covers a period from 1880 or so to about 1920, 1930, maybe 1935 in the latter chapters. And it talks about the development not only of modern health systems, but also of public health. And it names names. It tells you who the people are. It's a wonderful piece of work. I strongly recommend you read it. And I'll tell you this from my students. If you throw in some of the ideas or references from here, how they have affected the world today, it will guarantee, that's one of the ways you can maximize points and indeed get more than 100% points if you show me you understand this and can fold this work in as well. It's just a wonderful book. I think it's time for me to reread it again myself. Now, I have to tell you, I've lectured for, well, I'm going back to 2015 or so, about mandates and financial incentives for HIT at our program at Indiana University. So I thought, I'm not sure that the way I've done it, and you'll see the image I've used in just a minute, I said, let me see if I can get something out of ChatGPT. Can they create a better graphic to convey the mandates and financial incentives for HIT? So here's the prompt that I wrote for ChatGPT first and then for Gemini. You're a graphic designer helping me prepare PowerPoint slides for a lecture on the history of health information technology. Create an image of the major pieces of legislation that constitute mandates or financial incentives for the adoption or evolution of health information technology. We'll be talking a lot more about generative AI prompts later on in the semester. But I fed this into ChatGPT twice, and it said, oops, we had a problem. We're not going to give you anything. So I fed it into Google's Gemini, and here's what I got back. My first reaction is that doesn't look half bad. But pay closer attention. HIPAA, privacy, and security rules, 1996, no ending parenthesis. I don't know what privacy means. And that leading to, in terms of financial incentives, Medicare and Medicaid, EHR incentive programs, don't know why they're programs, and certainly to something called meaningful use, which I think means meaningful use, which was a measure we're going to study in some detail, how the federal government compensated providers for using technology under rules called meaningful use. That led to interoperability, requirability. Don't know what that means at all. Requirements, not quite spelled the way I would understand. Blocking in this case out of context. I think we're going to get, as you'll see below, when we get to the 21st Century Cures Act, we'll talk about information blocking. Not quite sure what they're trying to get at here, which leads me to MACRA, the Medicaid and CHIP Reauthorization Act, and what should be the merit-based incentive payment system. As you can see, I'm not sure what FISNTIV means, but I think that's what they're trying to get at. And then finally, we have promoting interoperability, not sure what language that would be, programs. So good ideas, really poorly executed. And if any of you students, I encourage you, allow you to use AI, generative AI. Tell me the prompt, show me the result, but audit the thing. Do not give me garbage like this that came straight out of ChatGPT, or in this case out of Gemini, because ChatGPT couldn't give me anything. So let me go back and show you what I did in the first place. I did this when I was teaching this class not as an asynchronous class. I was standing in front of the whiteboard in front of the class, and I drew this little sort of road, and I said, let's put some hallmarks on it and see if we can identify the milestones that have got us here. Now, this was the very end of 2016, so it doesn't include the 21st Century Cures Act, which was passed by Congress in December of 2016. But when did I start? I started in 2004 when the Bush administration created the Office of the National Coordinator for Health Information Technology. I think that was a very wise, prescient thing to do. Rather than starting with a bunch of legislation, they started with an office, a place, a group of people who bore responsibility for driving health information technology. That was followed in 2008, which was the year of the elections, and then led to the Mental Health Parity and Equity Act. Now, that didn't directly call out health information technology the way in 2009 ERA and high tech did, but it still said we're going to treat mental health in the same way, broadly, the same approach, and with the same level of significance and focus as we do traditional physical health. So the Mental Health Parity and Equity Act, in my view, had a significant impact on extending health IT to include mental health. That led to the Affordable Care Act, which really did a lot, again, not speaking as directly to health IT, but speaking to access to healthcare, funding for healthcare, and the nature of what would be compensated. So it had a huge effect on healthcare IT indirectly, leading in 2014 to the Excellence in Mental Health, carrying forward from the 2008 Mental Health Parity and Equity Act, leading to 2015 MACRA, which provided specific incentives for funding, and then 2016. And my point when I did this speech was that I thought it would take about 10 years till health information technology would morph into LHS, which is a learning health system. We're not there. There's been work. We're seeing progress. I'm really honored to see the work that folks are doing. Glad to be a part of it in some small way. We're not there. And so later we'll talk about the 21st Century Cures Act. In fact, we'll talk about it next. And we'll talk about the idea that we are not even close yet to really having a mature learning health system. So let's take a look at the 21st Century Cures Act. Passed in December of 2016, it is still being implemented. It focused on interoperability and open APIs, breaking down silos. It prohibited information blocking and improved patient access to their own information. One of the main ways in which organizations competed with each other, healthcare providers, was by saying, I own your health information. If you go to another organization, they can't have access to that information because you, patient, don't own it. I do. So it was a real barrier, and so the law was intended to break those silos down. It also was about empowering the patient and increasing usability for the patient to get value, part of a larger trend we talked about in Module 1 towards the consumer approach, consumerization of healthcare, and the movement towards the patient as their own CEO. Here's a good summary, and this was created by generative AI. In summary, the 21st Century Cures Act has shifted the health IT paradigm from a system of proprietary data silos to an ecosystem of open, accessible, and transparent information. It has created a legal framework that prioritizes the flow of data for the benefit of patients and providers, fundamentally changing how health information is managed and shared. Now, the two significant comments are that it's not fully implemented, it's still in process, number one. And number two, with the slashing in funding for the Department of Health and Human Services, which is where most of this is driven, we don't know what the future holds for the intention of the 21st Century Cures Act or any of the other preceding legislation. That is what we will be seeing real time. That is what will be in the news every week as we are together. Now that's enough. I appreciate it for those of you in my public audience for watching this. I hope that the slightly longer format gave you value. And for my students in B641, please proceed to Module 2, Lesson 3, when we'll begin to dive into the thrilling, exciting world of accounting to measure performance for health IT and health informatics.